Okay. Welcome, everybody. We're just waiting for more participants to join, and then we'll formally start the session. Okay, I'm going to get started. We still have more people joining. I would like to welcome everybody to the Summer Learning Series hosted by the Primary and Integrated Healthcare Innovations Network, and that has the lovely acronym of PIHCI. I am delighted to welcome you to our third session, which is Making the Invisible Visible, the Power of Patient and Community Partnerships. This is an unusual session because it is hosted by our patient partners for anybody who has the slightest interest in patient and community partnered research, which is really interesting. So you're going to hear from their perspective about this, how to do this, particularly in primary care. Before we get started and I outline how this session will work, I am going to read a statement that was developed by the Canadian Family Physicians, College of Canadian Family Physicians Indigenous Health Working Group, and it is a statement of acknowledgement of traditional land. And given that we are on land all over Canada, this is for virtual meetings. So we acknowledge that the lands on which we are hosting this meeting include traditional territories of many nations. We recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. We invite all attendees to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Thank you for listening to that. So how this is going to work today is I'm shortly going to turn the session over to our patient partners. They will introduce themselves as they go. We will have an introduction. We will have a brief presentation by three patient partners, and then an introduction to the rest of the Pan-Canadian Patient Advisory Council, who are our panelist members, and we have a guest panelist who I will introduce at the end. If you have any questions, you will note in this webinar series there is a function that says Q&A. So rather than putting it in the chat, please go to the Q&A and post your questions. I will be reading them after the panelists introduce themselves, and our different speakers and panel members will attempt to answer those questions. We do leave quite a bit of time for an active Q&A session, and this is your chance to learn from the people who are doing it, everything you might want to know about patient and community partnered research. So with that, I would like to turn it over to our patient partner from Saskatchewan, Brenda Andreas, who will introduce this session. Brenda, do you want to go ahead?
Welcome and thank you. Before I begin, I would like to just share with you that we're missing one of our colleagues, Ghislaine from Montreal, and we wish her a speedy recovery. Our other panel member is Kent from BC, and we hope that he will join us shortly. Let's begin. Let me introduce a little bit about myself. I'm Brenda, AKA Bunny. I live on the Alberta-Saskatchewan-Manitoba border. I live in rural Saskatchewan, and I've been a patient partner interested in patient-oriented research in primary care for approximately 5 years. I also have had a significant amount of experience within our local health authority, the Saskatchewan Health Authority, and I'm very excited to be here with you today. The significance of today is the voices that you will hear are all patients. As members of the Pan-Canadian Patient Council, we represent both diversity and we are all leaders within our healthcare systems. organizations. And many of us have had experience at the local, at the provincial, and at the national level. We're all interested in primary care. We're all interested in strategic patient-oriented research. And we're here today to share our expertise and our lived experience with you. We're here to start a conversation with you. We're here to connect and to build relationships. So if you're a researcher, a clinician provider, an academic, a policymaker, a funder, a patient, a community, a healthcare organization, let's find a way to engage. We would like to, as a panel, we would like to see more research being done at the direct care level with our frontline clinicians and providers and patients in their communities, as this is where most of us receive our care. We're here because what matters to us is informed, evidence-based, best practices, no matter where you live. We believe in people-centered care based on the 4 pillars of respect and dignity, information sharing, participation, and collaboration. We'd like to become visible together with you in our communities, in our healthcare organizations, and thank you. Over to you, Jill.
Thank you. Okay, we are going to go to our first speaker who will present on her experience, and that is Joni Cranston from Newfoundland and Labrador. Joni, do you want to introduce yourself and tell us about some of your experiences?
Oh, hello everyone. Yes, my name is Joni Cranston and I bring you greetings here from our beautiful rock, Newfoundland and Labrador. And I live on the most beautiful part of the rock in Grossmorn Park on the west coast of Newfoundland. I was going to try and get a slide so I'd have a lovely background and you could see where I live, but I'm not that technologically inclined, so I didn't manage to pull that off. And I have lots to say, and I'm timing myself, so I hope I don't talk too quickly. But there's 3 things that I really wanted to say. First of all, we are all patients. I have a new hip thanks to our system. We've all looked after others, our parents, our children, you know, family and friends with issues. So we're all caregivers. And I happen to also be a physiotherapist, and I've had the privilege of living and working here in this beautiful community for over 30 years. So I have a very detailed, intimate knowledge of my patients. I don't actually call them my patients, I call them my people because they're my community. I live and work among them. I know them as people, as friends, as neighbors, as well as I know some of their physical conditions. And I also know how they feel. And I'm asking them a lot more post-COVID or in this COVID time about how they're feeling. So one of the things that I wanted to do today is present their voice. We're making the invisible visible. And one of the things that I do as a patient partner is I give a voice to my people. So I'll first just talk a little bit about the different roles I play as a patient partner and my involvement. Then I'll give voice to what my people's concerns are. And then I'll talk about how I use my involvement as a patient partner to further do things in my community. Because my background, besides being a physiotherapist, I've also had 30 years experience in community development. And there's a lot of overlap. And I bring a lot of lessons from community development to my work as a patient partner. In community, we have community-based research. So I would love to see eventually patient-oriented research become patient-based research, patient-led research, people-led research, community-led research. And that's what I'm working for in my own community. So as a patient partner, I've been involved in the NL Support Network since it formed in 2016 as a patient partner. And I've really watched that network grow and evolve as people hone their skills as patient partners, working with researchers, and also working as council members, sharing information among each other, networking, sharing stories, and taking on leadership roles. So I do give a hats off and a shout out to my council members on the NL support unit, as well as to the excellent staff who support them. One of the reasons that I think that I see this movement growing is that the networks and certainly this Pan-Canadian Patient Council, they have excellent people behind supporting them, you know, talking us through travel plans and things like this. So thanks to all the staff and people who support us in our work as patient partners. So then I became part of the National Patient Engagement Task Force that made the recommendation that we form this Pan-Canadian Patient Council. And I think that's a huge positive step in moving the agenda forward nationally and connecting what's happening in the provinces. I haven't got involved in individual research projects so much. It's more like I like being involved at this committee level and hopefully giving a voice and having some influence in policy, as well as networking with amazing, intelligent people. When I get frustrated working in the system, when I come to one of these meetings and I see the intelligent, caring, compassionate people who are working together to try and improve our system, it gives me hope. And then I can go back and I can tell my patients, well, you know what, there are things happening. We are working to improve the system, and your voices are what we need to capture to improve it. So now quickly, what I'm hearing from my patients since I reopened my clinic on June 15th in the middle of these conditions, the most important thing they're saying is primary healthcare is an essential service. Access to doctors, nurse practitioners, physiotherapists is essential and must be maintained even during lockdown conditions. Because if not, people's health decline and then they're more vulnerable to viruses. These services can be provided safely. Doctors are doing a lot with virtual. Physio, I did some virtual and I got some great results, but the hands-on and the in-person contact is very important. And we can do this safely. We have masks and we sanitize and we screen and we take temperatures. And my patients feel safe when they come here. They tell me it's safer than Walmart. So if they can go and buy their groceries at Walmart in the middle of a lockdown, they would like the right to be able to access physiotherapy and other essential primary healthcare services, even during a lockdown. One of my patients who works at the hospital said he actually felt safer coming here than he did going to the hospital. So the second thing they're saying is that vulnerable seniors in long-term care have needs and rights that are being ignored in the name of protection. The rest of society, we can open up our bubbles, get haircuts, begin to socialize, and many of our seniors do not have that opportunity, and it's having negative consequences. In our province, in our hospital, no seniors have died of COVID in long-term care, but people have died as a result of the conditions imposed by COVID, of broken hearts, of not being able to see their relatives. One lady, quite elderly, put her knitting away. When her relatives could no longer visit, she put her knitting away, and she didn't last very long after that. Stress and anxiety have these physical consequences, loneliness and cognitive decline, as well as physiotherapy services aren't being provided to long-term care to help them maintain their mobility. So what happens there? So I think, and things can be done safely, and some seniors can even thrive. My mother is 96, lives in Victoria, BC, in her own apartment in a seniors building, and all during COVID, they all ate in the dining rooms, 6 feet apart, still socialized. She went out walking and on her scooter every day. So she's actually sharper now than she was before. That was all done safely. They don't even have colds and flus in that senior's place. Granted, I mean, she's a high-level senior, but she's 96 and she's vulnerable and she's surviving COVID safely. So please God, she survives so I can get in and visit her. So the third point is that not if, but when the second wave of COVID hits, access to primary health care needs to be maintained. In this level, doing all our precautions, we are doing it safely. We need to figure out how we live with this virus and not let our other healthcare needs suffer. Okay, I got maybe another about 2 or 3 minutes. So that's those primary points that my patients are making. Then what I want to just touch base with you is on how I use this in the community. So in community, research means you ask a question and you look for the answers. Community-based research is by the community, about the community, for the community. So I wanted to start, I was offering services down the coast 2 hours north in Port au Choix, where they had very little access to service. And the clinic where I was working didn't have a washer and dryer, so it was not convenient. So I talked to my patients, asked them what they need, said, we need a new clinic space. Someone said, I know a building down the road for sale for a very reasonable price. So we formed a board of directors, and that board of directors is directing the move towards this new clinic, which we call Great Northern Peninsula Community Place, and provides safe, accessible access to primary health care, plus a community kitchen where people can get access to healthy, safe, mostly plant-based, affordable food, plus a fitness center, plus a gathering place where even under conditions of COVID, we could make this building work, that you could have small, safe gatherings. So the other thing that happened to support that was a researcher that I was working with. She was doing research about nutrition in older adults on the whole coast of Newfoundland, St. Anthony to Port aux Basques, no small task. She approached me because in my clinic where I work now in an old college hospital, there's a community kitchen. So she came to talk to me about that, and we had a focus group and interviewed some seniors. So I told her about my clinic down the coast, and she said, "That's amazing. We should form a research collective about that. We should get a group of us together, of these people from the School of Nursing at Grenfell, and we should look at all the issues around the formation of this community place, how it reflects the needs of community, and what are the health impacts, what are the health effects of it." So we formed the Great Northern Peninsula Research Collective, which again, it's one of these places where I can go and meet and talk to all these amazing, intelligent people. And that gives me hope for the future of healthcare. So the movement has been put a little bit on hold during COVID, but I'm going to go down in a couple of weeks, meet with my board of directors, hopefully raise funds in community to start this new clinic. We'll need some government funding for renovations, and we'll be supported in our work by this research collective that includes a social geographer and includes people from the School of Nursing, and it includes an asset mapper researcher from Memorial University and a researcher who's involved in social enterprise, which is a very useful tool for community-based care. So all these wonderful things are happening, and I use my experience as a patient partner to facilitate these things. Now I see Jillian's screen come on, and I think I said a lot in 10 minutes, so I'm gonna leave it on to our next amazing speaker. Thank you very much for this opportunity.
Thank you, Joni. That was great. And yeah, Joni is in, I made the mistake of thinking when I went to St. John's, I'd be able to see Joni, and she's like, yeah, Jill, only if you want to come about 8-hour drive more than when you get there. So thank you, Joni, for that. Next, I'd like to turn it over. We're going to go, getting my directions right. We're going to go west. I'm turning it over to Lynn Mansell, who is in Alberta.
Morning, everyone. Great to be with you. I am, as Jillian said, from joining you from Edmonton, representing the Alberta PIHCI network. And I'm the current chair of the Pan-Canadian Patient Council. I'm recently retired from Alberta Health Services, where I was Senior Director of the Seniors Health Strategic Clinical Network. So I've always, and throughout my long career, I've always been involved with senior services, and now I'm a senior myself and experiencing several chronic conditions. But my main interest in being involved in primary healthcare research stems from my experience as a caregiver for my mother, who could not speak for herself because of vascular dementia. Together, we experienced the entire health system, from primary care to home care, occasionally, assisted living, acute care, long-term care, and palliative care. And now, with wearing another hat, I'm a board member with the Alberta Association on Gerontology. We're preparing recommendations to submit to the Alberta government on a new vision for aging, with a focus on staying in the community as independently as possible for as long as possible. One of the issues that I am focusing on as part of my contribution to that is improving end-of-life care. And as Joni mentioned, during the pandemic, many seniors at the end of their lives were isolated, some confused, especially those with dementia, and alone, whether they had COVID-19 or not. Some were in long-term care centers or hospitals where there were severe restrictions on visiting by family members, and some were at home where the caregiver and the senior were isolated from the rest of the community, and home care workers did not always come to work. Not something for our society to be proud of, but I think we're all learning from the experience. Now I'd like to switch gears for a few minutes and tell you a little more about our Pan-Canadian Patient Council and why I think it can make a difference to patient-oriented research in primary health care. Now I am using the term patient, but I wanted you to know that we define patients as individuals with personal, physical, or mental health experience with any aspect of the healthcare system, and that this includes individuals who might be called clients or residents. As well, it includes family members and or caregivers identified by patients as their circle of care. We were officially established in 2018 based on the recommendations of the Patient Engagement Task Force, which had patient, researcher, and National Council representatives. We have one member plus an alternate for each provincial network now. We're only missing the Northwest Territories, but we have great hopes that we will get a member soon. We aim for diversity in the type of patient experience, age, and ethnicity. 4 of our patient members sit on the Network Leadership Council, and we have approximately the same representation as researchers, policy leaders, and clinicians on that council. We have never met, all of us, face to face, but we're making very good use of the virtual world for our meetings, speakers, check-ins, webinars, and conferences, hopefully in the future. Our most recent activity has been consulting with other patients and our networks to define the priorities for the work of the council and the main issues for the primary healthcare system to address. And we're now turning them into a series of more specific objectives, activities with timelines. I just wanted to mention 2 of them, which I feel are important from my personal perspective for the council, the future of the council. First is to lead, the objective is to lead or co-lead processes to set research priorities and turn those into funded research. Based on what I have learned over the last few years involved with PIHCI, patient partner involvement in primary healthcare research has progressed a great deal. Many project teams are proud to include patient partners throughout the research continuum. However, research priorities are mostly determined on the basis of the priorities of funders, as well as the researcher interests and knowledge. There is seldom funding made available for including patients in priority setting. In my opinion, there should be a stream of funded research that is based on the priorities set by patient partners. We've had some experience with patient dens in BC and New Brunswick PIHCI networks, and I think that approach could be used at the national network level. This way, I think the research outcomes would be more relevant and the knowledge uptake quicker. The second thing is to make it easier for patient partners to participate in research. For example, the need now to have a university sponsor rather than a patient group as the key organization, and the requirement for principal investigators to have the appointments. These are barriers. Also, the common CV is complex and is biased toward academic qualifications in publishing rather than lived experience. One of the activities our patient council would like to lead to start off with is a standardized common CV workshop for patient partners, which could be part of an online educational and informational series for patient partners offered by peers. So in closing, I think our Pan-Canadian Patient Council is looking forward to spearheading a number of activities to take patient engagement in research to the next level. And we hope they will include many other interested patient partners from across Canada. I look forward to your comments and ideas.
Thank you, Lynn. That was fantastic. You didn't even leave me enough time to say, oh, you're running out of time. You got it down. That's fantastic. Okay, so next we're going to turn to Elise, who is in Ontario, and Elise has some slides to share with us as she shares her experience, and then we'll be going to our panel. Elise, are you ready?
Yes, I am. Let me just unmute and start my video and do all those things.
Okay.
I can't start my video because somebody has stopped it for me.
Oh, yes, Jamie did. Jamie, can you start the video and go ahead and share your screen though, Elise?
Yeah, will do.
Oh,
Okay.
there you.
So here I am. So now I'm going to share my screen. And there we go. And there. Okay, so hello everybody, and good morning or good afternoon, depends I guess on where you are. I live in Toronto, so I'm a very urban person, and I've been an acute care patient episodically since I was 20 years old. And around in my early 20s, I was nearly crushed in a car accident, and I've been somewhat accident prone since. So I know the system quite well from an acute care point of view. And I've also been a caregiver for my mother, who was a dementia patient in the Netherlands. So I learned a lot about the Dutch system. I have never worked in healthcare, so all of my experience as a patient partner comes as basically a neophyte or somebody new to the system and not somebody who's worked in and knows the system. And my professional background is as a software designer, basically designing software for large, complex financial services systems. Hence, I have a very big interest in digital health, particularly as it applies to primary care. And we've all noticed how in COVID, the whole virtual care thing has exploded and happened very, very quickly. So I'm quite happy about that. So what else can I say about myself? Not much, I think. I just wanted to mention, though, that Joni talked about physio should be available during COVID, and I totally agree. I've been recovering from a broken ankle, and I was just starting on physio when COVID hit, and I had to stop. And so I've been sort of faking it in terms of my exercises ever since. Now, I'd like to talk about an element of invisibility that I don't believe is noticed easily. So first of all, as a patient partner, and I've been a patient partner in research since 2011 in over 10, good deal more than 10 different research projects, I do have a voice as an individual person. However, patient partners as an independent sort of community of experienced patient partners are generally invisible. We're not visible as a community in our own right, independent of the host organizations. So today I thought I'd just talk about a project that did enlist an independent community. So how did this come about? The Ontario PIHCI network called Beacon, which stands for Better Access and Care for, and I have to read this here, complex health, something like that anyway. So Beacon was looking into digital health, and in the context of our rapidly changing world, and this is a world that includes the crisis of Facebook and Cambridge Analytica using the data from Facebook, raising privacy concerns, a world where people are producing health data on their own, both health and wellness data, using apps and devices that monitor, like Holter monitors or glucose monitors. This newer type of data is called person-generated health data, or PGHD. This data could be a source for research, especially when put together with the electronic medical records in the clinics or the admin data, the sort of billing data that the provinces collect. The question for Beacon, and ultimately for the rest of us, is on what basis is this data going to be used? What principles cover its uses? And more importantly, who should develop the principles? Clearly, patients and caregivers need to be involved, as it's their data, our data. So Beacon thought, why not approach a group of patient partners? They were aware of the Patient Advisors Network, or PAN, and so they approached us. Now, PAN is a, let me just go here, is a community of practice for patient partners, and it's completely independent. So we were contracted to develop the principles for patient-generated health data from a patient and caregiver point of view. So here's what we did. We led the project, and we conducted a survey of our community about what they considered the values and principles to be around person-generated health data. And we had discussions on our private discussion board as well. The next thing we did is we had a series of discussions with our innovation team about the results that we found from the discussions and the surveys and so on, to pull out of it what were the principles. We led this work with the administrative support from Beacon, and who helped us put together 2 stakeholder workshops that included healthcare professionals, private sector companies, policymakers, and of course, patient partners. This was a bit of a reversal because usually researchers ask for patient partners to be consulted. In this case, it was the patient partners asking the other stakeholders to be consulted. And this resulted in our report, which was delivered at the end of September of last year. So what was the impact of our work? Even before that report was finished, at the end of the second workshop, members of the Ontario Ministry of Health approached us and said that they would like to see as soon as possible a copy of the report, because the province was looking at revamping the privacy legislation. And so we gave it to them as fast as we could. The second thing that happened is that I was asked to present on the basis of this report to a consortium of people interested in developing health data strategies for Canada. And furthermore, on the strength of that, I was invited to join the Canadian Personalized Healthcare Innovation Network, or CIFIN, their policy modernization group, and subsequently also Research Canada's Policy Engagement Committee, so that the work that we did as a collective is brought forward to these different policy groups, and hopefully will have an impact. What have we learned? We learned really 2 things. One is we proved and we learned that patient partners can actually lead work. And there are other examples I've seen of patient partners leading work. The second thing that we learned is that patient partners as a community are a great source of collective experience and expertise. And I would say that's true not just of PAN, but also of the PIHCI, Pan-Canadian Patient Council, which is presenting this webinar today. And there are other sources of groups of patients. I'm thinking, for instance, of the health authorities. In Canada, many of the health authorities and provincial governments have patient and family advisory councils, and one could draw on them for a collection of patient partners who could give good, solid expertise forward to particularly health systems types of research looking to revamp primary care, say, from a health systems point of view. So I just want to conclude here by really saying that talk to us as a group as well as individuals, because that will really provide a very enriched source of expertise. And thank you a lot for giving me the opportunity to talk to you today. And I look forward to the discussion.
Thank you, Elise. I'm so impressed. You're much better at keeping on time than any of the researchers have been. This is fantastic. Okay, so those were our 3 sort of longer presentations, and now it's my great pleasure to introduce you to the rest of the panel. So I'm going to announce their names, and they'll take a few minutes to tell you about themselves and their thoughts, reflect their thoughts on their experience as patient partners. So this is alphabetical. I'm not going to do something crazy, which I usually do, which is trying to go by geographic location. I inevitably miss a province, so I'm not going to do that. So first, Mafo from Manitoba. Do you want to introduce yourself and share a few thoughts with us?
Yes. Hello. My name is Empa Begin, and I'm based in Winnipeg, Manitoba. I've been with the council for a year now, but I've been involved with the Manitoba Sport Unit for 3 years, doing patient engagement. So my interest in patient engagement is basically, I believe that when it comes to healthcare, we need to have all different perspectives. Canada is a multicultural country, and 20% of the population now is immigrants. And that number is expected to grow to 30% in just 10 years from now. So I think having different perspectives on healthcare and how it affects patients, different population, young generation, older generation, I think it's very important to have policies that are going to work for everybody. Yeah, like Ali, also I'm also interested in technology to improve patient health. I'm an engineer by profession, so I'm interested in technology and see how it can be used to improve patient care. Thank you.
Thank you very much. Okay, next we go to the East Coast. Olive?
Hi, everyone. My name is Olive Bryanton. I am from PEI and I live in rural PEI. I am new as a patient partner with this Pan-Canadian group, and I am very excited to be involved. As an older adult and an advocate for older adults, I am learning day by day the value of hearing from those who have the lived experience, and whether it's the lived experience of doing what they do in their everyday work, or whether it's the lived experience of a health issue. I think we all would benefit from hearing those voices. And as this group says, that those voices are the most invisible voices around. So we really need to have patient partners. I am involved with the SPORE PEI and am collaborating with them to build a network in our own province of people with lived experiences of all ages. So we are currently reviewing materials to adapt to our own needs. And we will, when we are prepared, we will be starting to recruit patient partners in this province so they can be advisors for us. I think this is a wonderful organization. And I just know that those with the lived experience are the ones who are the experts. And as healthcare providers, we need to hear from the experts. Thank you.
Thank you, Olive. And I would argue that as researchers, we need to hear even more, because we're far more inclined to go down those rabbit holes and maybe get a bit off track. And it's fantastic to have you help us keep on track and provide such a rich experience. Okay, next I'm going to go to completely the opposite coast. Kent, do you want to introduce yourself?
Sorry, a little trouble finding the unmute, as many of us sometimes do under these circumstances. I am Kent Lofsgaard, representing the West Coast, coming to you today from the shores of Jericho Beach in Vancouver. I come to this particular group through my initial involvement with the BC Support Unit during its founding efforts in the fall of 2016. And as a result of that, I was introduced to several related opportunities throughout various parts of the SPORE funded networks, as we call them. I am a patient by virtue of my lived experience of pediatric asthma and cerebral palsy, but I have dedicated much of my professional life to parts of the health profession as well, starting with paramedicine training, even while I was still a teenager, and then moving into various parts of health specialty, communications, clinical education, and research.
And yeah, as I myself struggle with finding the correct buttons at the correct time.
Here we are.
Yeah, exactly. And I have to tell you, I know a lot of people have been commenting on facility with technology, but our group has taken to the Zoom world like ducks to water. It's actually been really fantastic and enabled us to participate in a lot of ways that weren't previously possible. So there's always a silver lining. All right, I'm going to ask Kylie to introduce herself and make a few comments, and then I understand, Kylie, you have to go. You can't stay with us. Okay, so go ahead and share with us.
Great. Hi, everyone. I'm Kylie Peacock, and I'm from Halifax, Nova Scotia. I've been here for about 10 years, but I did grow up in Guelph, Ontario. I spoke at, I think it was maybe the last series, as I was representing PIHCI, which is building research for integrated primary healthcare in Nova Scotia. I've been involved with that network for a few years now, and that's how I got involved with this council. And I guess I'm truly patient partner. I'm not from the healthcare world. I try to bring in my lived experience of being a young adult living with multiple chronic conditions to the table. I think I am probably one of the youngest ones on the council. I think we're often a voice that's not heard. We aren't in the seniors category. We aren't in the pediatric category, but we are the people who, you know, get diseases at a young age and have to go through the entire system. So I've had many interactions with the healthcare system and tried to bring that voice to the table. In saying that, I always try to use my platform to say I'm a very privileged person to even, and folks who are on the other series would hear me say this, that even the fact that I'm called a patient is extremely privileged. All of us here who are on this council who are considered patients, there's people who are even more invisible than us who aren't considered patients, whether that is because they do not have access to primary health care, whether they have been discriminated against. So I truly like to acknowledge that, recognizing the privilege of sitting on this council, being able to take the time out of my day to do this work is a privilege. And I think as a council, we have a lot of work to do still, though we do have a very diverse set of stories and lived experiences. There is a lot of areas of diversity that we are missing and that we need to work on as a council. And so I continually try to bring that perspective and use the platforms that I'm given to bring that up. And that's something I try to bring to the different projects I'm involved in as a patient partner with PIHCI or with different researchers. Worked with a lot of researchers at the Nova Scotia Health Authority and with their patient quality and safety councils and teams there, and with researchers at Dalhousie University, and just try to bring that equity lens to the work that we do. So thank you, and I hope that people can kind of think about that as we all move forward in patient partner work and how we can use these platforms to lift other people up who are even more not heard or made vulnerable or who are even more invisible than people like us. So thank you.
Thank you, Kylie, and thank you for joining us while you could. That's greatly appreciated, and I understand that you have to get going. So, and that's a fantastic point. Of course, a lot of people have all different experiences with the healthcare system. There's a lot of people that are still trying to have experience with the healthcare system, which is shocking and appalling in a country of our wealth. And I think COVID has simply highlighted this issue. Okay, next, just before I introduce our next panelist, because she is from Quebec, it just reminded me, I forgot to say, si jamais vous avez des questions en français, vous pouvez toujours écrire ça en français, je vais faire la traduction. If you have to, if you would like to, if you're more comfortable expressing your questions in French, please do so. And I would like to remind everybody, please put your questions in the Q&A box. It's easier for me to keep track of than the chat. Okay, next is Karina from Quebec.
Bonjour everyone, I'm Karina from Quebec. I've been a patient all my life. I've been going through the healthcare system since I was 3, which is more than 40 years ago. And I've always felt invisible doing so. I've been subject to many researches, and I felt that even though I had a very, very big luggage that I was traveling with me all the time, I couldn't do much with it. So when I became a patient partner about 5 years ago, I started feeling visible in the system, which I thought was great, and that allowed me to give a voice to some patients that didn't have the privilege to participate for many reasons within some research groups, university, DCPP, CRPPP. I've been privileged to collaborate, and I think even though there's still a lot of work that should be done in order to have some proper settings and to understand how we can fully collaborate together and what we can bring up to the table. I think it's a very, very great opportunity that we have now to feel that we have something to give to the system and to the research teams, especially because what we've been going through as patients through the system is something very specific that can't be learned either at the schools or the books, in the books. So we have something complementary to offer you, and I really hope that if you have questions regarding that, I'd be happy to answer in French or English. Vive le Canada. Thank you.
Thank you, Karina. And I often tell my patient partners or community partners, you know, they have a PhD in lived experience, but I think with this group, you've moved beyond your PhD, past your postdoc fellow, and you're, you know, in your mid-career in terms of lived experience and expertise and what you bring to the table. It's fantastic. So next, I am delighted. One of the first patient partners I met before I became involved with PIHCI was Roger. So I'm delighted to hear from Roger. And so Roger, do you want to go ahead and introduce yourself and share a few thoughts?
I would love to. First off, I left my own picture up currently because, as you can see, I'm wearing nice clothes for this meeting. Johnny, I am in hospital currently. Will be till the first of next week, which will make about 5 months. Kylie mentioned about being young and being ill. The last young lady, she was ill for 40 years. I've been ill for 45 years, I believe. Now, it seems to be something happens every year, which drives my wife over the edge, literally. I am serving on a few things. I'm with the PIHCI National, PIHCI NB. I think I started when PIHCI was invented. And I don't have my picture. Oh, who's that? Somebody there. What I can tell you is that we're very lucky to be in Canada. We do have a lot of work to do in regards to serving safe, quality healthcare, first time, each time, every time. And that should be standardized right across Canada. And that policy, that thought process, nobody should be without that type of care, regardless of where you come from or your age. Although I know that in the mental health world, because I'm president of the Canadian Mental Health Association here in New Brunswick, is that's a silent voice on a regular basis. And I had the missed opportunity of seeing a service for my wife. Well, she was in hospital, and the service to my daughter while she was in the hospital at the same time. And there was quite a difference in the approach and attitude when it came to our mental health clients, whether it was compliancy, being compliant, or frustrated with the level of care for mental health clients. Through the COVID crisis, our mental health team was able to get up and running in three days. Our system's still not up and running for people older than 18 currently for video, even video information through doctors. I happened to come in before COVID and go through a couple of coding processes where I got my ribs broke and intubation, delirium, 5.5 months currently under how it works in a hospital during COVID. And very strict rules regarding even crossing in between levels in the building. Everything's locked, total lockdown. I wasn't allowed a visitor until I guess it was a week and a half ago when I had my first visitor. So I know full well the impact it has on patients being isolated within a hospital. Can you imagine being a mental health patient and being in a hospital? Not unlike this one, but very different in attitude, I think, in perspective of the clientele. As you can hear in my voice, I'm a strong advocate for this, and been in mental health in the nonprofit sector for 20 years. I've been a patient for much longer, 43 years. I mentioned the PIHCI, MD, PIHCI National. Love the council for the patients. Absolutely love it. It's a great idea. It's a must, in my opinion, to do. If you're going to use patients as partners, not use, but ask them to be partners. I think having that council available and having such a multifaceted experience within having healthcare provided is a tremendous resource. You can't buy that. You have to unfortunately earn that, and that's a hard road. This time is no example. I had my wife. This is a shout out to those folks who have to live with us patients who have chronic health issues, and she was asked twice what code level I was at during this period of time. Now, we never talked about that from a personal perspective as to what I wanted if something happened to me. But my wife was put in a position, a very uncomfortable position twice during my current stay. And you choose one way, you choose the other way, you die or you potential for life. I'm here to tell you there is life after death. If it's deemed so by higher powers than me, but I'm very happy. This is actually my first meeting back, and very happy to be back in the loop, in the swing. I know I got to pick up with PIHCI National and PIHCI NB because I lost 5 months and a half because I don't remember a month before I came in. But the brain is marvelous. Work itself, I was able to recover. I can tell you delirium is very real, even though it's not real life. These are real imprints on a person's life or on their brain, but actually just as if it happened. There's a whole new segment for mental health that I'm thinking about called delirium, surviving it. It's also given me an insight on how the healthcare system is under duress as a result of the COVID-19. And the fact that they were even able to serve patients within this hospital is simply amazing. Not have one death. New Brunswick, I give an applaud to our government. I may not agree with them all the time, but they certainly closed things fast, and it saved lives, with the exception of the Low Hamilton thing. But that actually didn't. Those people are recovering, most of them. I think there's one in serious situation. But being in a hospital, being by yourself, gave me lots of time to think about what's important. I think this work is important. I won't mention anything that's not important, mind you, but the things I think that are really important are this involvement with patients across this country, that partnership with researchers. I've done a little partnering with researchers in the past on a couple of projects here in New Brunswick, and there was one in Manitoba, one at McGill University, and one in Vancouver that I think I can remember the deets on. But very happy to be here in my Johnny shirt, and I'll tell you what a Johnny shirt is if you ask me. But otherwise, thank you very much.
Thank you, Roger. We are delighted to have you. I think honestly, Roger, you must be one of the toughest human beings I've ever met. And we're just so thrilled to have you back in the group. You've been such a strong voice for patient partnership and mental health and for everybody. So that's great. So I have one last panelist who's our guest surprise panelist who has joined us to show his support for the importance of patient partnership. And that is Rick Glazier from CIHR, the Institutes for Health Services and Population Research. So Rick, do you want to say a few words before we open the Q&A session? That looks like it's already filling up quite nicely.
Okay, hi everyone. Good morning and good afternoon, depending on your time zone. I'm thrilled and delighted to be here as a guest / interloper in this wonderful discussion on the power of patient and community partnerships in research. As part of the Summer Learning Series, I want to acknowledge and thank the National Coordinating Office, Jillian, Jamie, and all that went into the Summer Learning Series and this session. And my hat's off to the panelists, the presenters, the messages that you bring and the participation that you have in research is truly inspiring. So I'm going to start with a statement that says, you know, on behalf of the Institute of Health Services and Policy Research and CIHR, is that I see you, we see you, you're not invisible. However, we need to be constantly reminded. We absolutely need our feet held to the fire, because what you might call the research industrial complex is largely run by scientists. And scientists delve into great detail in their topic areas, the researchers. They think they know the important questions, they frame those questions, they write the grants, they get their funding. And you know, a lot of the times that's good, but a lot of the times they're not asking the most important questions, the most impactful questions. They have difficulty recruiting. Their answers or results are not the most meaningful to the people affected, and the lack of engagement of patients, community members, caregivers, family members is very obvious in the way that a lot of research actually never gets to be applied or takes an inordinately long time. So I would say that you are not invisible. All of the folks who presented today are powerful, engaged, amazing folks, and you've hit on some really important topics and themes. But I would say from a research funder perspective, it is terrific to be always reminded about the importance of these engagements and the visibility that all of you need to have and how we might help support that visibility. The COVID-19 pandemic has meant that patients in many ways have actually been less engaged in research because many of the funding opportunities, first of all, everybody's at home, many people are stressed, they have caregiving responsibilities for their parents, their children, they're doing homeschooling, just a whole number of challenges of COVID-19, the social isolation, mental health and substance abuse challenges, the family violence challenges, et cetera, et cetera. So, and then when the research opportunities that are COVID related have come out, and there have been many at CHR, about $155 million of research funding specific to COVID-19 just since February. But many of those have run out on such a short timeline that between announcement and application has been only 10 days, 2 weeks, 3 weeks. It's really not enough time to properly engage either with policymakers and for sure, unless there already are existing patient relationships, as many of you have. I think all of you have wonderful relationships in your various settings across the country and with the PIHCI network. But many researchers lack those connections, and now they're put in a position of writing a grant very quickly in very fraught times where they really don't have a lot of time to be able to do that on a short timeline. So I guess I would say that the visibility of patients has never been more important than right now. Funding opportunities need a longer runway. We are hoping actually to help do some matchmaking between patients and those who have already been funded who would like to engage with patients. So the phase 2 funding that was just announced 2 weeks ago for COVID-19 involved a lot of health services and policy research, some certainly in primary and integrated care, and that would be highly relevant for PIHCI. And that we're happy in the cases where the investigators would like and where patients and citizens would like and families and caregivers to get involved or to do some matchmaking. We're hoping to get into that space and be able to facilitate it. The last thing that I'll say just at this point is that coming back to what Lynn had mentioned earlier, is that we would love to understand your priorities and for you to be engaged in a priority setting process. We are so fortunate. Our institute has an advisory board of 14 people. Elise is one of the 14 who sits on our panel. We also have another patient, Thomas Beaudry, on our panel, but we need her voice, his voice, and all of your voices and many others to help us keep on track with setting priorities. And so I'll stop by saying we are so open and would love to hear your priorities, both in the COVID-19 context and in the overall context of developing our strategic plan. And if you have ideas for how we can do that, we have held a number of forums, webinars, those kinds of things, but we'd love to have more ideas and more engagement about how you can get involved in helping us to set those priorities for our investments, both for COVID-19, which is kind of short to medium term, and then also over the longer term, the next 5 to 10 years. So I'll stop there, but just absolutely delighted to be here and happy to answer any questions as long as they're not about CIHR funding per se. We want to keep the focus on patients, I hope. But if it's about patients, I'm happy to answer questions.
Thank you, Rick, and thank you for showing up to support this really super important initiative. So I'm going to ask my panelists and speakers to turn their videos on, although you can stay muted for now. We have 9 questions already in the inbox, and one of the things I do want to mention is that we have completely revamped our website. I will post it in the chat shortly, but we are going to have a section of the website is dedicated to the activities of our Pan-Canadian Patient Advisory Council, where they have been working very hard on priorities and categorizing those into short, medium, and long-term goals, as well as things that are procedural versus different types of objectives. And it's been a fantastic learning experience for everybody. It's a lot of work. This group is incredibly hardworking and incredibly generous with their time. And it's really interesting. We found some very interesting gaps as they've moved ahead in terms of what's available for people who are interested in patient-partnered research from the patient and community side and being involved in different levels, despite all the work that's been going on in Canada. And we've also, I believe, identified some opportunities. But so please, I will put the website there, you can go. But I'm going to get to the questions. So the first question is actually for Joni. And it was and I think actually you'll see this in a few of the questions. People are asking about involvement. So how were you chosen to be the voice of your people? So do you put yourself out there? Did somebody approach you? So Joni, do you want to spend a couple of minutes? And maybe other people can talk about how they got involved. Were they solicited or did they put themselves out there? So go ahead, Joni.
I think it's kind of been by default, because ever since I moved here and started being the physiotherapist, the only one on this whole coast of Newfoundland, then I was always talking to patients. So I was hearing their concerns and relating it to how the system worked. And then through my involvement with community, I got involved in many community initiatives. So if somebody had a question, I was networked very well. So if somebody had a question, oh, ask Joni, she'll know. So there was no formal election held, but it was just through my involvement in various levels of community development. It was through my community development contacts, the Rural Secretariat that folded, that I got hooked up with NL Support. And so then whenever I become involved in these groups, when I'm talking to my patients, I spend 45 minutes and now an hour with my patients. So COVID gives me more time with patients because everything takes more time. But as we're doing their treatment, we have a chance to talk about issues and bigger issues. And I'm always asking them, how are you feeling about COVID? What do you think they could do better? I have this opportunity to have this voice because I punched my hours on the committees and the councils and through the emails. So I have an opportunity to have a voice. What would you like me to say? And then I always relate back to them. Do you know what? There's these initiatives, and so I guess because I'm connected and it's the type of person that I am, and I love being connected and I love being involved, that, because then I always say to me, would you like to be on my board? No. Okay, well, would you like to be my patient partner? Can I ask you questions? Can I ask you how you feel? On all my intake forms now, there's a tick box for using their information for, can I use your information for clinic-based research? i.e., without using your name, can I say that I have 3 patients from down the coast who need hip replacements who can't get them, kind of thing. So they're very interested in the concept of what I'm doing as well, I think, and interested in the concept of gathering data about their own health. Track your blood pressure as you eat the plant-based food from our kitchen. Track your blood sugar, So they're interested in getting involved. So I guess because I am the one who sits on these committees, that's how I get to be their voice.
Thank you, Joni. Is there any other, Brenda, you want to comment?
Just a really brief comment. What Joni's describing is leadership, informal leadership that many patient partners take on in their healthcare settings. And the second piece about that is that it's about partnerships. It's the best thing about COVID is that, especially here in Saskatchewan, and if you're not familiar with what we do here in Saskatchewan, we're a brand new health authority. We're not at kindergarten yet. We just got out of our diapers. So we're growing and learning, and our focus is in people-centered care. And there's many different ways that you can view healthcare. And until you've had exposure to more than what happens at the direct care experience, at that clinical one-on-one experience, it's really hard to see the many different views. There's accreditation with metrics, there's research with evidence-based best practices, there's communications IT, there's clinical standards. There are so many different ways that patients can get involved in research. But the one thing that we've done in Saskatchewan that's really helping to move us forward is, about 3 years ago, I went to Skipper, Saskatchewan Center for Patient-Oriented Research, and I said, how come you guys don't have a place where patients can connect up with researchers? Well, it took 3 years, but we now have a website in Saskatchewan on the Skipper website where clinicians, researchers, academics looking for patient partners who are interested or want to become involved in research can connect together. So, a clearing place where we can all come together. It's fledgling. It needs a lot of support and a lot of work, but it's there. I'll stop there, Jill.
Okay, and I'm actually going to go on to the next one because I realize we've got 9 questions to get through and none of them are like easy peasy. Sorry, that's somebody calling me. there's two things I want to let you know. One of the things that's unusual about our council is it's primary care. So we're not, our partners aren't a specific disease. They are a spectrum of their involvement with the system, their caregivers themselves, and like Lynn pointed out, they've often been through the system from the perspective of a caregiver to a patient to involvement in research. So that is actually quite unusual because most patient partner associations are disease oriented, and that's not primary care. The other thing, for those who want to know more, our patient partners, who are always game for whatever insanity I think up, and they're pretty good at telling me I'm insane, but they're still willing to go along with me. We're going to do a podcast, and we're going to talk about patient partnerships, and that will allow us to look. They're not going to be super long, 15 to 20 minutes, but it will be with each of our partners, and they'll talk a little more about their experience. So some of these questions you have about how do you break into this, how do you start this, how do you promote it, why is it taking so long? We're going to explore those in podcasts. So there will be more information available if your questions here have been answered too briefly. So with that, I'm going to go on to the next question, which is initially targeting Lynn, but I think the others can weigh in on this. What methods do you use or recommend for patient priority setting? So Lynn, I know we figured this out the hard way, but you want to speak a little bit about that process, because you spend a lot of time and effort on it.
Well, I think we have, as a council, been consulting with our members and many others, the networks, on what the priorities would be for a council like ours and where we should focus in the primary healthcare system, what needs to be fixed. But in terms of the methods, I guess I just wanted to mention that I've personally been involved with a DEN approach in my previous role and career, but specifically around patient DENs. I think what they do and have done quite successfully is kind of flip the equation where instead of researchers solely focusing on what the requirements in the proposal are for all kinds of different things, different headings, they focus on what the patient panel or advisory group would like. So you pitch your idea early on in the before the proposal has even been written. You pitch your idea to a group of patients and say, how does this sound? What do you recommend your involvement should be? And is it important to you? So I think that kind of gets things started in a different way than pitching it to the requirements of the research funder. And then, well, we have to have a patient engagement section, and we need to get a couple of patients to agree. And I think the barriers to doing it better, first of all, is funding, because there's no money before you get the project funding. So there's no money to help get patients involved early on in the priority setting. Secondly, I don't think there's very explicit requirements to have patients involved. I mean, it's patient-oriented research, so I guess it's implied, but and there's a question asked about how to get, how would you get advisory groups or not front and center. And then thirdly, I think there's a perception that some kinds of research don't need patient involvement. I was on the patient panel in Alberta a couple of times where we were providing input on PIHCI funded research projects that Alberta was involved in as one of the partners. And I remember them saying, oh, well, we would ask every time, how will patients be involved in this project? And a few times they said, well, it's not really necessary because it's not that kind of project. It's not clinical, and it's really more about data, or it's more about system change, or it's more about policies. And so I think a lot of it is perceptions that patients don't have anything to offer, or perhaps, it's just not necessary because it's at a higher level. So that's mine. I'm wondering if someone from our Nova Scotia rep, Roger or Kent from BC want to comment, because they did have DEN processes.
This is Roger. They do tend to overlook the fact that you have a previous life other than the patient. They don't know. I've had that impression even in New Brunswick, but we do have a really good piggy den here. I've been involved from the beginning on research projects, and I have to remind them at the same time that I was somebody other than a person in a Johnny shirt today, for example. Patients are people too, and they have that resource, they have that background. They could be anything from an engineer to a technologist to researcher. So that's my take on it, Lynn. Open to all.
So Kent, did you want to describe your experience with the DEN in BC?
Yeah, in BC, we had a little bit of a different priority setting procedure that's actually described in a paper that we managed to get published in BMJ Open that I think is now posted on our provincial website for the BC Primary Healthcare Research Network. And that just started by taking our ragtag group of patients and asking them essentially what matters to you in healthcare. And then we also circulated a survey to providers as well, talking about priorities from the provider perspective as well, and some of the barriers to care that had been experienced on either side.
Okay, thank you. I think, yeah, there's two things there. One is, and we found this with policymakers as well, like it's, you really do need to have an opportunity before your research progresses, and it's how that gets supported and how that happens. And I do, the patient dens, where the patients are the dragons deciding if your idea is fundable, is very, very helpful and useful feedback. And will help with your priorities, plus give you information to supplement your grant. But I think we are trying to think of other mechanisms to make those connections and make them happen. So I'm going to go on to the next question. Actually, the next question is about the report that Elise mentioned, and I believe you already typed your answer in the chat, right, Elise, that it's available at www.beacon.ca for your report?
Yeah, you can go to the Beacon website, and that's where it is.
Okay, great. There is another question for Elise. I know some of our patient partners, by the way, will need to leave at different points because of other commitments, but the question for Elise is how many people are part of PAN, and how do you tap into that patient advisors network? And I think this is an issue for a lot of people, because there's always a delicate balance when you're having a patient partner where you have them engaged, but you don't, I don't know, take advantage or overuse or exhaust your partners. So Elise, do you have a little more insight on PAN?
Yes, I do. First of all, PAN has members from every province in Canada. Unfortunately, none of the territories as yet. We're well over 200 people, which doesn't sound like a lot, but we've done no marketing. So it's 200 people over a couple of years, word of mouth only. And the provinces of BC, Ontario, and the collection of the maritime provinces have a percentage represented in PAN that's greater than their percentage of their population in Canada. We're a little low in Quebec. The West is almost equal, and we have nobody, as I said, from the territories. So I hope that gives people a little bit of an insight. I've also put the PAN website in the chat. So you can, or if you want to, you can just go to patientadvisors.ca and you can see our somewhat outdated website, which we're in the process of revamping.
Okay, thank you, Elise. So we have 14 questions and less than just over half an hour. So I'm going to go to the next question. So the next question are, what are some unique aspects of patient-oriented or patient-led research involving children and young adults? How can we facilitate patients leading research priorities in the context of pediatrics? I know Kylie had to go. I don't know if any of our other patient partners want to answer this. I actually do this type of research. So if one of our panelists can't answer this, I will briefly give you an answer.
If I may, I'll just chime in here because.
Oh yeah, Kent, of course. Go ahead.
I have some relevant experience from yet another of those pesky branches of the strategy for patient-oriented research called Child Right. And to my surprise, I have been so far the only former pediatric patient who has come back to an organization like Child Right and been engaged with how can I support you in your training, in your research, et cetera, et cetera. Child Right is another one of those arms that I was introduced to through my involvement in the BC support unit initially. And we do have several interesting patient-oriented pediatric research projects underway. They tend to be what we call brain-based in nature. I think that the explanation I was given was that the reason that they prefer the term brain-based as opposed to neurological is because for the most part, our research projects have so far left out the spinal cord and the rest of the peripheral nervous system in terms of the conditions that we will, most regularly consider. But many, many exciting things are happening in the area of, pediatric brain-based research with Child Right.
Yeah, there is a SPORE network that is completely dedicated to adolescent care. One of the things, because I do knowledge translation, implementation, engagement, is I'm actually developing tools that are age appropriate. We have a bad habit of just taking the adult world recommendations and thinking they will work for a completely different world. So I'm developing a role-playing game that assesses health-related quality of life preferences, especially when those preferences go against our social norms. So there is some interesting work going on. I would say it's unbelievably undeveloped. And I think Roger is going to speak a little bit because he did a lot of work mental health with young people, and then we'll move on to the next question. But it's an area that it's desperately needs engagement because, hey, we're all adults, so we no longer know what it's like to be a young person or a young person in the healthcare system. So it is a undeveloped area. Go ahead, Roger.
Well, I am a young person in the healthcare system. No, I'm not. But anyway, yeah, you're right. I am with Access New Brunswick, or whatever's going to happen there with Access New Brunswick. We did get some opportunities to put some safe places in communities, like Elsie Bucktook, up towards Rexton, I guess, somewhere handy there. I can't remember, but safe places where people can come and be themselves as adolescents. They did all kinds of wonderful things. I had a week up there at Elsie Bucktook and took in all kinds of traditional and non-traditional things while I was there, which was really, really cool. And took in all the communities, English, Francophone, Aboriginal, and made it a safe place for all of them. And it's on the Elsie Bucktook. That's what Access. Worked on a project, or helped on a project with UNB called Navicare. Navicare is for, and it's got a website, and it is a service for how to access the services within New Brunswick. We hired a social worker, did the research, did the all that policy and governance and all that wonderful stuff nobody likes. But it got out the door and it's serving the community. And that's what I like to see about research is the end game for research. I like to be at the beginning, but I also like to be seeing what happens in the community. Canadian Mental Health Association still has a lot of programs I'm forgetting what it is, but it's a youth-based one. Anxiety and depression, all those kind of things for all ages, including youth. And we have ISD teams now within our communities, which are working with youth from kindergarten to grade 12 for mental health and addiction issues. So that's my input, and I'll turn myself off here.
Thank you, Roger. Yeah, the mental health is another one that is, although there is a mental health SPORE network as well. And all the SPORE networks have very, very strong patient partnerships. I have to say that's one thing they're doing quite well. Okay, I'm going to move to our next question. Question for Karina, although I think, again, this is something actually that all of our patient reps can speak to, our patient partners. It's, you mentioned that by being part of a network, it has allowed you to give a voice to your experience and the experience of others. Do you ever worry about the idea of carrying the responsibility of representing others? I think this comes up a lot. There is a difference between being a patient representative and a patient partner, but I will let Karina speak to that.
Being a patient partner is no magic, meaning that I cannot pretend to represent or to be the voice of every patient, especially due to the fact that I'm a white female privileged. But that being said, as I was saying previously, I've gone through life with a big luggage, carrying a big luggage with me of all my sickness experience and going through the medical system and talking with a lot of people, which allows me to think with a bit of leadership that I can give a voice to some questions that are being asked or some perspective that are needed from my point of view. Of course, it's still my own personal point of view, but it is a voice like others, but I think that due to the fact that I've acted as a provincial director, as an example for the Canadian Transplant Association, or that I'm very active on the different platforms or on websites and communities where I can discuss and ask questions and ask opinions. And I've been a caregiver to my father and my sisters. I have a big baggage of different experience of life with sickness, so I can give a perspective, and it's sometimes it's impressive to know that some questions come quite often. Some projects are still very different from one another, but the needs of patients are very common and are very similar from one project to the other. We all have common needs that are easy to identify, and sometimes that are very, very far from the perspective of research teams. And I'm not afraid to say that I might not know the answer to the questions that is being asked to me. And sometimes I go to people to ask the proper questions. And I'm also very close to some refugee communities because I have friends within the Arabic community. So their perspective is also very close to my life. And I tend to look with a big lens and not being attached to my own personal needs, but to the needs that I know that are out there. So I think this is very important to acknowledge and to keep in mind while we act as patient partners. Thank you.
Thank you, Karina. And Mapo had to leave. as Roger pointed out, all of our partners have other lives that take up their time. So she had an appointment she had to go to. Did any of our other partners want to say anything about this? Because this does come up, but I think there is a distinct difference between being a partner and bringing your experience to being an official representative. I don't think, correct me if I'm wrong, but I don't think anybody's claiming to represent a specific group. It's more to bring the patient perspective into the physician. And it's interesting, Karina, that you said that, you know, the same questions come back. I do translational research, and I have noticed that the issues when you're trying to get evidence into practice are the same, whether you're talking about a super specialized pediatric glioblastoma genetic test or a, you know, trying to reduce low value costs in care in primary care. Same. So the things come back, and I think this is the sharing of what those common issues are is something that can make patient partnership really strong. So anybody else want to comment before I move? Elise, and then I will move to the next one. Go ahead.
Yeah, I just wanted to add to what Karina so eloquently said, because I do agree with her wholeheartedly. I don't ever feel like I'm representing all patients or even a segment of patients. But we can share our experience and our point of view. The other thing is that the more experience I gather and the more I listen to my colleagues and learn about their experiences, the more robust my understanding of some of the issues are. So that I think is helpful. The other thing I feel is, and I'll end with this, as a patient partner, I know where my limitations are very often, and I can sometimes direct people to gather other points of view from other types of people who might be able to fill in where I cannot. So I think that is a responsibility that I feel, is when I can't provide something, that I can direct people to where they can get it.
Thank you, Elise. And I think one of the things that will, as we go through the answers, the questions and answer them, what you'll see is that this council are very experienced in patient partnership. They bring a lot of years of doing this. They started in this long before it ever became a thing. So they do have a spectrum of experience. So the next question is, any suggestions on how we encourage or influence researchers to include patient partners in the early stages of planning and design projects? So I know there's some practical issues here, both in terms of funding and how you engage, but, and we've heard about patient dens, but does anybody else have some ideas about how we encourage people? Elise, and then for some of and Karina, go ahead.
Yeah, so coffee comes to mind, which in time of COVID is a bit tricky, but some of the best relationships I've developed over the years with researchers started over coffee, floating ideas. And these were researchers who reached out because at that time I didn't know anybody. And we were able to develop trusted relationships that led to my involvement in a series of the different projects that they wanted to cover off. So I would say that that's one way in. It's not easy without something more organized, like a roster or a group that supports patient partners, and it's not easy without funding. Then it becomes really individual initiative. So I'll just leave it at that.
Okay, Karina, you wanted to say something as well?
Researchers, well, I'm going to say education due to the fact that I've always had the feeling that whenever I come within a research group, if it's for the first time, it often comes out to they don't really know what to do with me, or they don't really know what I can specifically bring to the table. And whenever everyone becomes acclimate to the situation, and then a bit of a discussion and coffee, perhaps, as Alex said, it becomes clearer, and we have to identify whatever we can do and whatever they want us to do. So clarification of what everybody needs to do, and to say to the research teams, confidence needs to be established, and then them not being afraid of us, trying to think that we want to have a role, a research role within the group, and that we have something, we really do have something to offer.
Lynn?
Thank you.
Oh, I just wanted to say there's
And then Roger.
some excellent engagement going on already. But maybe some teams, some project teams, I'm talking about after they're funded, don't know what those best practices are, and if there is some way they could be shared. I've been involved with projects that have excellent leadership, and I've been with them all along. And it's even when we come together in person, and we used to come together in person, there was always, the patients were always listened to with respect. They were always involved at the same level as the policymakers and the researchers, and always with an eye to how could this be used after this is over. So, and then there have been others where it's kind of parceled out a little bit more discreetly, like we'll have patients involved with this piece, but not this piece. And I think they all have their merits. Obviously, as early as possible, before all the decisions are made about organization and implementation is always best. But as I said earlier, I think if there was some way to share best practices amongst researchers, or to indicate on the proposals some ideas about how and when to involve patients a little more explicitly, then they would respond to that.
Roger?
For the researchers, if there is a pause in your work, stay connected to your patient partners. Otherwise, you're not going to have patient partners because they become disenchanted and confused as to what exactly is going on. Then you get a call a year down the road that they want to talk to you about something. That connection, that communication, all has to be a piece of it, and that respect at the table. Worked on a project in New Brunswick here with PEI and Sackville, New Brunswick, and NB, and you just leave your titles at the door, and you walk in, you sit around the table, and you discuss things. It's meeting people, monopolizing on their whether they have an education in this or that, or just purely experience. Accept them as who they are, and be steadfast in that, and respectful of the fact that it may cost the patient money to go talk to you versus not. I think taking care of groups. Sorry about that. Taking care of those patients through communication, through mild expenses, whether it's a little bit of cost, I don't know, meal, or I like to break bread with people. And it's a great way to find out a lot about a person. So I would say trying to organize these groups so that you can actually meet patients. I sit on a patient advisory council for the health authority here and the regional health authority, and as a patient advisor as well. And I'm going to shoot that phone. But to me, go to those groups. There's groups out there. Like we had it's called the CAC for years, Community Advisory Council, that I'd chaired for several years. And that's where they reach out to. They reach out to people that are doing stuff in the community already. Word gets around that he'll do this, he'll do that. He'd be a great fellow for that. And that's how that works. a lot of word through voice to voice with people that are in different walks of life. It's getting to know them on a personal level, and I'll call it a professional level as well, and professional courtesy. You may be a patient, you may be a patient with grade 2 education or multiple university degrees, but with that ultimate respect of that experience, I think that's a must. I look forward to it. I actually got involved before they even started it because I put the question to a professor at the university about a funding she got that was already out before it was even formed. So I think that's all I got for now. Thank you.
Thanks, Roger. Joni, you wanted to say something, that I'm going to speed it up because our questions have increased and Rick's going to say something and we have 20 minutes. So we're going to answer a lot quicker, but they're very similar. You're going to see a lot of the same questions coming up. How do we do this? How should it be done? What's the education? So Joni and then Rick.
Yeah, so just very quickly, I guess maybe where the research collective that I'm involved in Newfoundland was, they came to me as a patient partner, as the person kind of involved in the project on the ground. They came to me and said, we would like to study what you're doing. I had a conference call with them or Zoom call with them last night, and they're like, how do we get to meet with the community when we can't come down because of university restrictions? We can't travel there and stay overnight. How do we meet with the community? So I said, I'll ask my board. I'll ask the patients how you can connect meaningfully with them. So I think, especially when projects start with patients and start from community and build up and research to researchers, then you see a different way of it working. So maybe if we shifted more to patient-led and patient-initiated research and bring the researchers in, then you'd get a different flow.
Thank you, Joni. Rick, you wanted to say?
Yeah, just very briefly, I want to endorse that, Joni. I think research can and should start with patients and with communities and bring the researchers in. That would turn the paradigm, the dominant paradigm, on its head, and I think would be really terrific. I think the power of relationships that many people have been referring to is extremely important, and having pre-existing relationships is obviously ideal. People you work with, researchers who know you, policymakers who know you, providers who feel comfortable with you. And that's a primary purpose of having the PIHCI network, having the sport support units, is that kind of meeting place, that kind of place to interact. And CHR, for many of its funding opportunities, has something called a partner funding matching tool, or a partner matching tool. And we heard a little bit about this in Saskatchewan, where there's a fledgling website where patients can express their interests, researchers can express their interests, and presumably with the idea of calling each other up or doing some kind of matching or doing some kind of connecting in that setting. And so I don't know what you think, Jill, and what other participants think about the PIHCI network, the National Coordinating Office, all of the networks across the country of that kind of matchmaker kind of role, where people don't have existing relationships, researchers don't know who to call, patients don't know who to call. Having some kind of a place where people have listed their interests, where they could be connected, and where researchers could have a one-stop shop, let's say, to find patients to engage on their work. And the same with patients wanting to do certain kinds of research could look for the kinds of researchers that are working in those areas and open to those approaches. So just to say, I think that PIHCI already does a whole lot of this work. And these matching tools are probably quite important for people who don't have existing relationships.
So I will speak to that briefly, and it answers one of the other questions that Denise had posted, saying, can a central repository be set up where planned research projects can be listed and patients can choose, see and choose what's important to them? One of the ideas I had, but I need like people with AI experience. I've often thought this is a lot like dating, right? Like, researchers are super nervous about doing this. Patients are super nervous about doing this. Policymakers are even more nervous, just in case you're wondering. So we're all like, oh, I got to go for coffee with this person. This is going to be super awkward. What do I say and how do I do it? And and it's one of those things. I think it actually gets less awkward with time. So what I would love to do, not that I have any familiarity with this, but I'd love to create a research spore type Tinder application. Because if you're looking at me as a researcher, if you look at what I've published, that's what I've done. It's not what I'm interested in. So there should be something where I can say, this is the type of research I do, this is what I'm interested in, and you can swipe right or left, depending on whether you're interested. But I want to be able to do that for my partners too. And policymakers want to be able to do it, because a lot of times they're looking for people to give advice. And there's certain topics where I could give answers very quickly on, because I've been doing this for 20 years. And there's other topics where it's like, okay, that's a new research program. So I think the idea is, how do we use these like cool apps that people are using to date, but figure out how to do that to match patients and researchers and policymakers. So put my idea out there. Anybody's got expertise to contribute to it, they're welcome. But that's where I think we need to go in the future to make this really take off. So there's another one of my crazy things. Elise, and then we really got to move on to the next questions.
I really like that idea, but I think we also need to be able to add sort of references, because that would make it a slightly more robust. Oh, I've worked with this patient partner and she's really good at this, but maybe that's the place where you should hire her for, if you will. But I think that's the big thing that's been missing, is this matching tool. Just a quick side note, in one of my previous incarnations, way back in the early 80s, I worked for a temporary help business, and it was exactly that kind of thing. So I've always thought this would be a great application for the research world. Anyway, that's it.
Yeah, so I'll have to see about, Lynn, go ahead. And then
just really quickly, I think there have been attempts made to match researchers with patients before, but it's tended to be more in the being a, shall I say, subject, rather than being a partner or being a co-lead, because I'm in one of those projects right now, and it's very limiting just to be somebody that is has high blood pressure. So I'm more interested in how that project was put together, what results are they seeing, and so on. And I'm going 3 years without knowing anything except them knowing about my blood pressure. So I think you have to have, and those are important too. I mean, the more patients involved in the better, but there's kind of different levels, and maybe it could be set up in that, with that perspective in mind.
Thanks, Lynn. And so I'm gonna follow through with this, because it's an idea I've been thinking about for a while, but it has to be something that's really easy to update, both from the patient side and from, because as I get funding, or as I progress, or as I develop experience, my interests and what I'm looking for and my partnerships, and as we said, this isn't funded. The front end isn't funded. So I think somebody had a question about, why is this taking so long? Why is patient partnership so difficult? Because the relationship building is not funded, and relationships are key. That's why we're all talking about coffee and having a meal together and discussions. It's relationship built research, which we don't teach, and we don't acknowledge, and we don't acknowledge the investment needed to make it happen. And that, Madge, hopefully answers your question, which is, patient as partner has long been a topic of interest, conversation, research for at least the last couple of decades. Why do you think it's taken so long to have this concept embraced by the healthcare system? And I would say that we don't fund relationships. I think SPORE has gone a long way to change that. I was a very steep learning curve for everybody. And the way we train people is that you have an expertise, and we don't acknowledge that lived expertise is just as valuable as my 12 years in how to do health research. So I know that's a really brief question to your answer to your question, Madge, but I think we've been touching on this as we go along. So I'm going to go, and I do want to bring up one comment that was made, saying, you are correct, primary care is not disease focused, but works within a healthcare system that is biased cognitively and politically, diagnostically, and clinically to disease. 100% agree with that statement. It's evident by limited research investments in health prevention, absolutely, generally disease specific, and more importantly, health promotion. Then that's big areas of primary care. If health research funding wants to get serious, it needs to support patient engagement. It starts with patient connecting and talking among ourselves, not only as takers and consumers, but advisors, experts, the primary healthcare system. So that wasn't a question, it was a comment. And that, but Madge, that partially answers your question. We have a hospitalist-based system that is still very much, as Rick pointed out, the funders are scientists that come from that environment. And in primary care, we're far more used to engaging with patients because we know there's so many evidence gaps. We know we're not putting the emphasis on the right things, but you're talking about a massive paradigm shift to get to this to work, and that doesn't happen easily. Although COVID has certainly kicked us further down the field when it comes to a paradigm shift. Elise.
Yeah, sorry. Yeah, I was just thinking about what you were saying, and you were talking about relationships not being funded. So much of healthcare is transactional and stays transactional. When you think about research projects, they are very transactional. You do a project, it has a beginning, a middle, and an end, and boom, it's done. So it doesn't lend itself to the development of relationships. It's really an uphill battle in some senses, and a commitment from the participants that relationships in fact endure. At least that's been my experience. So it will take a shift to go from things like fee-for-service and project-based research to thinking more long-term or more relationship-based or more even community-based research, which I think is where we need to start putting more emphasis, if I can just stick my oar in on that one.
Absolutely. Mike has asked about patient-initiated research in Newfoundland. He works with Joni. And do the panelists have any experience, good or bad, in patient-initiated research? I think actually, Mike, our panelists have a lot of experience, which we don't have the time to share with you, but I would suggest you reach out to them, and I will address that specifically in our podcast. But I think especially, I know New Brunswick did Patient Den. I know that the other SPORE units have patient. I've been to presentations where I've been listening to the genetic science, I've been listening to the clinical science, and then I've been listening to patient-initiated research, and it's so fascinating. And I think that's something that SPORE has done really well in supporting. But I'm gonna be really brief on the question because we have only a few minutes left. Okay, so Heather has asked, what strategies can patient partners use to advance their presence as full partners at the boardroom decision-making tables that often set priorities for research at provincial and national levels? There are opportunities there. I know CIHR has patient advisories, as Rick mentioned. Finding them less obvious, and the level of being welcome to do that is completely dependent on the decision makers. What I suggest you do is if you go to our website, which I'm going to post here, if you look at the map and you go to your province, it'll take you to that pick-in, and they're the people to contact to say, how can I get involved? How are you involved with decision makers? How can I be a part of that? So it will vary by territory, but I know that pick-in's been, because we have a policymaker as part of the tripartite leadership for each of our networks, they're trying very hard to advance this and support the patient partnership. Okay, one of the things that, go ahead, Lynn, before I read the next question. Lynn, you muted yourself instead of unmuting yourself.
Sorry. With respect to COVID-related research, which seems to be getting a lot of attention and funding, and rightly so, I think there has to be ways found to get patients on board in spite of the short time frames, because this going to end, as we keep hearing, it's going to continue, and we've sort of seen a bit of a backsliding in terms of patient involvement in the early stages of research, because researchers are scrambling to get their proposals in. But what could be more important to have patients involved in than this kind of research, which has impacted patients so greatly. I don't have the answers, but I think some of the discussions about pre-existing relationships is part of it. And maybe having some patients involved early and then using them to involve more as time goes on. But I really think this is a great opportunity for patients to become more involved in really critical research.
Excellent. Elise, and I've asked, there's a few people that have posted comments in the chat, in the question and answer thing. I've asked them to transfer that to the chat, which we can save, but because only the panelists can see the Q&A questions, it's not open to everybody. Okay, Elise, go ahead. And then we have
just a quick comment.
Questions.
There is something called Can COVID, which is a Slack-based community of researchers and patient partners and a whole bunch of people interested in doing COVID research. I'm on it, so I get some of the opportunities and so on. I would encourage people who are interested in COVID research to have a bit of a look at that.
Great. Okay, so there's two questions from Joan that are sort of similar. And it's, how do you help prepare patients to be involved in primary care research, education opportunities, mentoring, etc.? And as patient partners in research, do you feel there's a difference in role, skills, engagement with that of patient advisors, partners in the wider health system quality improvement efforts? So I'm going to start with that. But again, this is something that CIHR has posted a funding called National Training Entity. There will be one funded, and the whole idea is to make, so there's resources sprinkled all through different projects and networks and things on how to help you as a patient partner. I know Nova Scotia's done a lot of work on this. I know BC's done a lot of work on this. Our own patient advisory council is trying to compile. So there will be at a certain point a place where you can go and see what's available. And the group I'm involved in, we're trying to develop a curriculum that would be appropriate for all our stakeholders. So for policyholders, researchers, patients that want to be involved in this. There is a spectrum from advisor to almost like patient researcher. And I think our council represents that spectrum. They've done all of those activities, and it requires different levels of training. But the idea that, so depending on what you want to do, depends on the skills you want to say. And even my mom recently said, you know what? I want to be able to read an article meaningfully, a scientific article, so I can have a discussion with my physician. So where do I learn to do that? So that's what we call critical appraisal. And I don't actually have a great answer for her, and I'm not even sure that resource exists. So there will be eventually a compilation of those resources, but I think that this is one of the gaps we've identified in our group, is that sometimes what we think should exist and it's really obvious doesn't, and we're hoping to change that in the future. So again, please go to the website, which can one of you actually look up the website and pop it into the chat while I deal with our last question. Just before we, on the last question, because many of you will have to go, our next session is going to be hosted by BC, and it is actually going to build on this session because they're going to talk about quick COVID-19 primary care surveys that capture clinician and patient experiences during the pandemic. So that will be July 28th. And you can, the thing will go out with that, as well as a survey to ask you what you learned from this and if you have suggestions for future topics. So if there are any outstanding questions after that, you can go. I would like to thank Jamie Demore, who's coordinator for our network coordinating office and who is all the heavy lifting behind these series, as well as Stephanie Hindle, who is our summer intern and has been helping out, especially with the patient council and their work and priorities. And CIHR, we have many funders in Picken. CIHR is the main one in terms of funding the network coordinating office and our networks. So, okay, so the last question, which we'll end on, and I do want to thank our patient advisory council. You guys are troopers. This has been a fantastic session. I love when I not only get to participate, but learn. And I think this comes through, somebody asked, as a patient partner myself, I'm told I can only represent and speak for myself, my own experience. Following up on Joni's answer about representing others, do any of you worry about your own biases may filter what you hear from others? Just before the patients deal with that last question, I want to let you know that patients aren't the only one with biases. My training introduces biases in how I view things, which is why I find patient partners to be so valuable, because I need them to check my biases. And so, okay, so Roger, very quickly, Roger, and then
Okay.
Joni, go ahead.
Very quickly, I see bias in mental health. Well, not daily for the last 5 months, but prior to that, with my duties within the Canadian Mental Health Association and my own daughter who has schizophrenia. I see the differences in the way people look at her in the stores, in the hospital, wherever we go, except for the Mental Health Recovery Center, which is closed because of COVID. So that impact on 150 people that go there on a regular basis really are struggling. So I got off track there on that a bit, but anyway, the biases are there, and it's something that we have to look at from the patient perspective as well as a panel or council perspective. Okay, bye. Thanks.
Thanks. Joni?
Yeah, I am aware that any of us, we all have biases, so I try to keep myself honest by always questioning, is my bias here? And by always asking and confirming with my patients, does what I say reflect your views? So I'm always checking myself, and I think we should all do that.
And I'm just going to ask our remaining panelists to have a couple of, like, you can speak to that or just a final word. Brenda?
Here's a quick bias for you, the inequities in healthcare. And I live in a very rural, remote area of Saskatchewan. I'm not way north, but I'm way south. My answer, to answer that question, I would say this to you. I don't worry about whether I'm going to live or die with my health trauma when it comes. I worry about, is that ambulance, is that local provider going to be able to get me where I need to go to get the complex care that everyone else receives that lives in urban settings? It's about geography.
Thank you, Brenda. Lynn?
I think just to throw in the mix, we all live in provinces which are part of a political machine. So I think there can be biases introduced by the political system, and we have to check whether we're reflecting those or if we're offering an alternate view while still carrying on, I guess. So I think about that. My family and I have all different perspectives on how the health system should work, and unfortunately sometimes it kind of devolves into politics.
Yeah, doesn't everything devolve into politics these days? Elise? Still on mute.
Sorry, yeah, can you hear me now? Yeah, so I very much agree with Lynn, and I think that's actually a very important point. And I think we've seen that with COVID, that the old way of doing things where the experts know what they're doing was the default setting, and therefore patient partners were not included in the COVID planning, at least here in Ontario, the way they could have been and should have been. So there are definitely biases. And I also think that there's a tremendous bias about how people see patients. I think there's sort of an invisible person with a little blue Johnny gown, as Roger would say, in people's minds. And I think that's part of why some of us rebel against the notion of patient as being a sort of something stuck on our forehead, if you will, because we become this sort of vulnerable other. It's sort of an otherizing of what a patient is. And that's part of some of the bias that I see, even amongst the most well-meaning of researchers and healthcare professionals.
Thank you, Elise. Karina, and Kent, you're up next.
I was actually reading the comments. I'm sorry. I didn't have anything to add. It was a great session. Thank you all.
Thanks, Karina. Kent?
Yeah, on the question of bias, one of the biases of my own that I am the most aware of is something I call topical favoritism bias. And I do have certain pet topics that I tend to like better than others. And when I am being asked to fairly appraise something that is maybe outside of my core areas of interest, I have to be aware that topical favoritism may occasionally creep in. But from my own personal perspective, I think that something that patient-oriented research still really struggles with is both what to do with the health professionals who became patients who tend to forget their health professional perspectives, and then what to do with people like me who were born patients but became health professionals of various kinds, and how do we marry all of those perspectives to help them get along better.
It's an excellent point. As many of you have mentioned, this is just one of your roles. And as far as I'm concerned, the more roles you can bring to the table, the richer the discussion. So our challenge will be, how do we keep that discussion meaningful, moving forward, and not exploitive, especially as we want to try and reach people who have typically been excluded from the system, whether it's research or healthcare. So with that, I am going to call our webinar to a close. It's been fantastic. Thank you to our patient council. You are amazing as always, and I always learn something new with you, which is, as a researcher, that's always a thrill and a pleasure. And thank you, Rick, for joining in and weighing in. And I hope this has been helpful and useful to you, and some things you can take back to your colleagues at CIHR. So everybody have a wonderful afternoon. I do check the website. I don't know if that ever got posted. It's Spore Pickin, PIHCIN. If you're looking for updates, and we will be updating that, and hopefully within a few weeks you'll have our first podcast up and available so you can hear more about how this process works in reality. Okay, thank you everybody.
Bye-bye.